Okay. So last week we talked about kind of differentiate normal versus abnormal aging. And then the bridge to that is then trying to diagnose mild cognitive impairment or early cognitive impairment and the steps that are required to do that. So we'll walk through this together. One of the big emphasis on this talk is really tools that are better to detect this than what we have traditionally used, right? So I introduced last time this idea of screening, particularly with an 88 questionnaire. Um, and then we have all these screening tools on our website. The as far as good other bedside screening tools that are even more sensitive than these, we'll talk about today. And again, a simple plea to stop using the MMSE. Um, it's important, actually, one of the probably the most important part about this talk is trying to differentiate when you diagnose someone with mild cognitive impairment, is this a reversible cause or not? Well, you have to do the workup in order to determine that. So we'll talk about what things can cause reversible MCI. But then when we're pretty convinced, hey, we've ruled out all the reversible things, this is an early Alzheimer's process, or maybe an early Lewy body process, or an early vascular process causing MCI, why is that important to diagnose early? It's extremely important. So this was the algorithm we walked through at the end of the talk last time, and we screened someone with an 88, right? They had abnormal cog testing, and then now we're talking about mild cognitive impairment. So we'll have a case that represents that. Again, this slide, differentiating this is extremely difficult, but it requires a thorough workup. So the typical scenario is someone that is over age 65 presenting for their yearly Medicare wellness visit. You ask if she has any concerns with memory, and she says that she's having troubles with names, but really is unaware of any other issues. You even perform an MMSE screening, and she scores in a normal range at 28 out of 30. She's got a family history. She's of the right age where you want to start getting a little bit more concerned. And so you ask if it's all right if they fill out an 88 form, especially her husband, right? Because she may not remember all of the memory issues. So if you have him fill this out, right, he's checking 3 boxes. There are a couple concerning things going on, especially repeating questions, and sounds pretty much like a short-term memory problem. So we would want to, move on to maybe a better screening tool. And so, that word on the MMSE, the idea that a normal score is that, how do you know if that's not MCI? Well, multiple studies have looked at this, but basically, the MMSE was designed in the 1970s before MCI was even a concept. Mild cognitive impairment was a concept, right? And one study, it was as low as 18%. So MMSE is just not a great tool to use when you're trying to detect very subtle or mild cognitive impairment. It can be specific when it's clearly abnormal that actually you're probably dealing more with a dementia, but not MCI in most cases. So when we say to try to increase our detection, right, we want to screen the population that is at highest. So I had this slide last time talking about prevalence, right? And so we know that with increasing age, prevalence of MCI increases, and so does dementia, right? So you can double these numbers, for dementia. So if you had MCI plus dementia, it's roughly 50% of individuals in this age group, right? In order to improve our detection, right, that's where we have to use better screening tools than MSE, and these are the 3 that I talked about last time and introduced. But this is also where it's really important, if you do detect early changes, that you rule out the reversible causes, because that's as important as anything here. One word on the MoCA, so the Montreal Cognitive Assessment. So I assessed this when I was at Mayo Clinic, and we have detailed cognitive tests on a large group in a Mayo Clinic study of aging, and about 53% of those that had detailed testing were considered cognitive normal had a score below 26. It depends on the population you study, but some cutoffs for the MoCA may be overly sensitive. So in our study, 24, seemed like a better cut point. The other problem with the MoCA is it now requires certification, technically. which costs money and training to kind of complete, which helps standardize the test, but obviously is a unnecessary cost for most clinics. We use this short test of mental status, which we've got on our website, so I'm not going to spend too much time here, but basically it's a very similar test to a lot of different cognitive screeners, especially the MoCA. When I directly compared the two, it takes a little bit less time, it has better specificity and the same sensitivity for specifically what we're talking about today, mild cognitive impairment. And compared to the slums, it takes less time. So should we refer for further testing in this case, right? We had the 88 that's positive. She had a 3, a score higher than 2. Now, one other note, even if you do a good screening tool like the STMS or like the MoCA, and she scores normally, maybe she scores, 26 out of 30 on the MoCA, should you consider further testing? If she's got a high education background, right? Sometimes patients can compensate pretty well. And it's not like we only look at a score, right? Let's say she gets 26 out of 30, but she misses 4 out of 5 on the delayed recall. That's still concerning to me, right? You have to be mindful of the overall clinical picture and not just look at a score. So in this scenario, this is where we might think about getting more detailed testing that can take education and age into account for some sort of standardized neuropsych test. So if we do that in this individual, this is what the results showed. Basically, everything came back normal except for when we did usually what we do to test memory is have them try to remember 12 words, right? Which is an impossible task, but there's a certain age-based norm that we're looking for, and she really struggled with the memory domain. And so the diagnosis from the neuropsychologist was that this looked more like an amnestic, which means short-term memory, mild cognitive impairment. So what does that mean? What do we mean when we say mild cognitive impairment? We should define that. So, mild cognitive impairment is just some sort of bridge between normal aging and dementia, right? We know there's got to be something in between those two things, and that's what mild cognitive impairment is. For most patients, especially with this specific type of amnestic MCI, it's usually due to an early Alzheimer's process, not always, right? So we got to do the reversible things. But if you get diagnosed with amnestic MCI, about somewhere between 30 and 40% will transition to a dementia stage within about 5 years. Some people will say about 10% per year risk, right? The variability in that rate of progression is what's really difficult right now. Now, one, we don't have biomarkers in every patient that gets diagnosed with MCI. I think that would be really helpful. But it's also important to realize that some of these causes of MCI are reversible. And so we even see some patients revert back to normal cognition when the reversible cause is addressed. And that's partly why it's so important to diagnose them with mild cognitive impairment, because then you go looking for those reversible causes. And if nothing else, you're going to help address things that might progress to dementia faster, even if they've got an early Alzheimer's process. When we think about the severity spectrum of Alzheimer's disease, this has drastically changed compared to 10, 15 years ago, right? Everybody used to just think of Alzheimer's disease, dementia, those are interchangeable terms. They're absolutely not. That's part of what you'll learn when we kind of do these lectures, and especially with the dementia causes. So not all causes of dementia are Alzheimer's, and Alzheimer's disease can happen before dementia. So we have mild cognitive impairment due to Alzheimer's. We even have changes happening in the brain 10 to 20 years before someone has clear symptoms, right? So there's a whole spectrum here of brain changes that are happening that we're just now realizing, right, when we follow folks over time. There's a gray line between mild cognitive impairment and dementia, right? It's not like there's this clear black and white line. Sometimes it takes me asking a very pointed question, could this loved one go and manage their medications and finances, or deal with an emergency in the house, get to where they need to go driving, all these kind of activities of daily living if the spouse was not there for 2 weeks, right? And if the spouse would have a lot of concerns, they're like, actually, I'm doing a lot of those things, and then we're actually talking more like mild dementia because we're talking about something that's impairing their daily life. Obviously, with the caveat there being a change from baseline. Um, I introduced this table last time. So again, when we're talking about mild cognitive impairment, we're talking about, okay, somebody generally has memory concerns, either the spouse or the patient, right? But we also see impairment on objective testing. So in our case with the neuropsych testing, there was abnormal testing, but activities of daily living are normal, right? And that's the differentiation between dementia and MCI. And so when we come to the, sort of etiology of MCI, that matters with when we're talking about, is this patient going to progress or not? So figuring out what's causing the MCI is one of the most important things that we do. Now, there's a whole group of neurodegenerative diseases that cause MCI, and we can see non-amnestic MCI versions. So these would be folks that might have more of executive impairment or processing speed or visual spatial impairment, not directly memory. In those cases, generally are Lewy body disease or frontotemporal disease or Alzheimer's disease variants. So some of the atypical variants of Alzheimer's, and then vascular disease. When we're dealing with a primary memory problem or amnestic MCI, most cases are Alzheimer's disease. There's another one here called late disease that we're learning more about, more common in patients 85 and older, actually. So usually not something we see in earlier MCI cases. So those are the kind of neurodegenerative causes, but even more important is recognizing what are the reversible causes and ruling them out. And so when we talk about that, I wish I didn't have a list of patients that we've diagnosed as B12 deficiency, right, in the memory clinic. But, you have to be screening for this. As patients get older, 65 plus, they might develop intrinsic factor issues with absorption. They might have had bariatric surgery. They might have had other absorption issues. They may not be absorbing B12 as well as they normally should. So you should be screening for B12. Thyroid disease is almost always screened yearly, so I'm not too concerned about that being a cause. Oftentimes what we'll see is someone's TSH is high, and then it's like, well, actually they were on levothyroxine, but because of their short-term memory problems, they haven't been taking it, and now the TSH is high, right? So it's usually sort of a warning sign that something's been going awry with the medications. So getting these types of tests. Now, I used to always have like RPR and HIV really just for, if it's endemic in that area, if it's a high-risk population, you should be screening for it. Syphilis cases are up quite a bit since even 2018. So, maybe it makes more sense to be screening for this more regularly than we currently do. Hearing and visual loss, right? So these are big ones that can contribute, especially hearing. So if somebody has hearing loss, that can, I always tell patients, how do you tell a difference between a memory problem and a hearing problem? If you can't hear what's being discussed in the conversations, how are you going to remember it, right? And so hearing just has to be evaluated and treated if there's issues there. Medications, so basically, patients that are on anticholinergics, especially when they're over age 65, that's a major problem for the memory system that relies on acetylcholine for memory, right? So these are probably the biggest offenders of medications I see in patients that come through the clinic. The daily use and cumulative use of these medications are at least associated with increased odds of dementia. So there's not a direct mechanism there other than perhaps predisposing someone, unmasking changes earlier because you're blocking the major, neurochemical that's important for memory. Untreated sleep apnea is a big one that gets missed, and any sleep problem really needs to be addressed if present. Stress, anxiety, depression. Now that's tricky. Sometimes those things, we can see mild behavioral impairments before the mild cognitive impairment starts, but treating those things, right, it makes sense because sometimes we see complete reversion of MCI in someone that has uncontrolled anxiety, depression. So in our patient, if we rule out these causes, so this patient got a sleep study done, They had an apnea hypopnea index, or AHI, of 20, which is moderate sleep apnea. So CPAP is recommended. They didn't have any hearing or visual issues. Their B12 was technically normal, but it was 230. About 10 to 15% of patients below 400, especially if they've got memory and balance issues, it just makes sense to go ahead and supplement this, so they can be intracellularly low. TSH is normal. SSRIs, because there were some, she was no longer doing her hobbies, she was withdrawing from social activities, so starting an SSRI makes sense. We generally rely on things like escitalopram or sertraline to start there. She was taking Tylenol PM for sleep because she's had long-standing insomnia for years. So we recommend switching that over to melatonin. And then if melatonin was not enough, low-dose trazodone, focusing on sleep hygiene and other things that are non-pharmacologic. And then she was on oxybutynin for urinary frequency, and that's highly anticholinergic and has been shown in study over study to contribute to cognitive impairment. So switching her over to something else that does not impair memory is a good idea. And so the untreated sleep apnea story, right? This is a major risk factor for vascular disease in the brain. It puts stress on the heart, so it's a risk factor for AFib, heart attack, and stroke. And we're now seeing a risk factor for Alzheimer's disease. And so it's associated with amyloid positivity in the brain. And then treatment of it is even more important. We're going to have a whole talk on sleep later in the course of talks, but treatment is associated with reduced all-cause dementia, especially in patients with MCI. And so other than age, we know age being the biggest risk factor of developing early changes in the brain. If you're female, most cases of Alzheimer's disease are female, but what about other, males are at higher risk of Lewy body disease, so early stages of Lewy body disease causing MCI. First degree family history increases our risk by about 2 to 2.5 times. It's not a deterministic thing, but it increases our risk. ApoE4 seems to be the strongest genetic predictor here, but it's highly prevalent. So somewhere, depending on the population you study, somewhere between 20 and 35% of the population has an ApoE4 allele. I show you a breakdown here in the bottom of at least what we've seen with African Americans versus European Americans and the breakdown of these different alleles. If you have one allele, it increases your risk by about 3 times. So slightly more than knowing you have a family history, right? It's a slight increase from family history. But if you have 2 alleles, that's a pretty big deal. That's a large increased risk, over 10 times increased risk. But it's important to note that you can get Alzheimer's disease without these alleles, right? You can get other causes of dementia as well. Vascular risk factors are probably under-recognized, especially high blood pressure. So hypertension, hyperlipidemia, we just talked about sleep apnea, diabetes, smoking. These are all risk factors for MCI, and then hearing loss as well. So should we, can neuroimaging help? Like, why do we recommend an MRI scan? Well, an MRI is a pretty good biomarker for, is there neurodegeneration going on, right? So what we'll often look at is a detailed scale like this called the medial temporal atrophy scale. And this lets me look at these really important memory structures here that I highlight in red. These are looking at what we call the hippocampus, or basically the medial temporal lobe. And if we're seeing a lot of shrinkage of these structures, then that's a pretty good indication that that's what's causing their memory problems, right? And this is exactly the pattern that we see in patients with typical Alzheimer's disease. We also are able to assess for vascular disease in the brain when we get an MRI. So you can see this individual at the top, they've got a couple white spots in the brain. Everyone's going to have a few of these if you're over age 65. So these are normal aging changes. But here at the bottom, this is not normal aging changes, right? And so some patients can develop vascular dementia when the vascular burden is high enough. So we go back to our patient, right? We got an MRI on this individual. We had lots of reversible stuff to work on, right? But we still, we're concerned. They've got a family history. They've got positive 88. They've got an abnormal neuropsych score, so we get an MRI scan, makes sense too. They've got a little bit of white matter disease, but this is not enough to drive symptoms. When we look at their memory structures, these hippocampus structures, and then compare it to our scale, right? We see very clear shrinkage of these structures. It fits best with this picture right over here. So, I can confidently say that this individual, right, has probable early Alzheimer's disease driving these changes, driving their amnestic mild cognitive impairment. Still important to treat all those other reversible things because that's what's going to help try to slow down the conversion to dementia, right? We have to focus on those things that we can treat. And the point of all this, right, is that these cases are complicated puzzles, and neuroimaging is an important piece of that puzzle. So you want to be as sure as you can about what you're calling it. And this just helps be more sure about that. You could go another step further in this case, right? I mean, especially when we get blood biomarkers, we could prove that this is an Alzheimer's process, right? You could get spinal fluid in this patient to prove that too. This individual we enrolled in a research study, so there's all sorts of different research studies going on at KU. One that we're currently still enrolling is this TDAD, which is therapeutic diets in Alzheimer's disease. So it's comparing a ketogenic diet versus what we currently recommend, the Mediterranean diet. And so, the most patients that get involved in these studies, there's some sense of either empowerment, right, that they're kind of fighting back against this disease, but also the altruistic response, right? If it doesn't help me, hopefully it'll help someone else. A lot of these patients have seen mom go through this or grandmother. They want to help out the next generation too. So, but in order to get someone in a study when symptoms are early, you have to make that diagnosis, right? And that's partly why an early diagnosis matters. So other things it does, it helps promote autonomy, right? If you find out that their mild cognitive impairment is due to early Alzheimer's, right? You're involving that patient early on in long-term planning and treatment choices. You're helping give family an understanding of why did they forget my granddaughter's graduation party, right? Well, there's something changing in the brain. It's not like they didn't care, right? There's a clear change happening. So an understanding of disease process is another reason why a diagnosis is important. It improves outcomes, right? So when patients and families can come together early on and understand these things, it can delay transition to long-term care. It can help get caregivers that needed support even early on. We can start to prevent elective surgeries and delirium prevention, right? That can worsen symptoms to dementia. So we'll have a whole talk on delirium prevention and how important that is. You can start to remove medicines that could be contributing and increase in that research participation. So hopefully that is helpful. I think that this idea of we have to move up the window of diagnosis, we have to stop diagnosing people at moderate dementia stages, right? There's not much I can do once there's been a ton, billions of neurons lost. Our research studies don't impact that as much, right? We have some research studies for that stage, but it's not as much of an interventional research study at that point. And utilizing these tools can help us recognize these things sooner. I can't emphasize enough the reversible causes, especially things like sleep apnea. I think that's probably the biggest one that I see get missed. So if a patient has any amount of increased daytime sleepiness, they've got pretty significant snoring history, right? They've got an elevated Epworth sleepiness scale. Even if you look in their mouth and you see a narrow airway, right? There's lots of reasons to consider a sleep study if you're kind of meeting some of those check boxes that I just mentioned. And then we kind of defined these MCI definitions here. So I'm going to go ahead and stop there. I know we're right around 20 to 25 minutes. So.